Good afternoon, everybody. This is Dr. Dana Herganani, Chief Medical Officer for the Oregon Health Authority, kicking off our twice weekly webinar series for healthcare providers. I'm joined here today by Dr. Tom Jean and Dr. Ariel Smits. We are glad to be joining you again today. As usual, we are going to go through a variety of updates, including our epi data, as well as new guidance, and address your questions along the way. You will remember from past webinars that we are unable to answer your real-time questions, but we encourage you to write them into the chat box because we do collect them at the end of the webinar, and we will bring those back for responses at our next webinar opportunity. So outlining our agenda items for today, we'll start with some COVID-19 epi updates. We'll then head into new testing guidance that was released, I believe, today. We'll outline some antibody testing in response to questions that continue to come forward on this topic. We'll also talk about use of homemade masks or face coverings, and we'll talk about some additional specific questions that you had alongside questions regarding the healthcare workforce. And finally, we'll just highlight Governor Brown's reopening Oregon framework that she announced last week before we close. So starting with our epi update, this data is as of yesterday. New data will be posted for today later this afternoon. As of yesterday, there have been 1,956 positive COVID-19 cases based on our testing results, and unfortunately, a growing number of deaths, now up to 75 as of yesterday. You'll see here that we have an additional 38,089 negative tests in the state, and as always, we like to acknowledge that community transmission is broader than these testing results show. They do not reflect the full impact of COVID-19 in our state. We are also bringing back to the current COVID-19 hospitalizations vantage point. As we've shared before, this data is reported to the Oregon Health Authority daily through our hospital capacity web system, or HOSCAP. All Oregon hospitals report this data to us. There's two different buckets of data we look for: patients with either suspected or confirmed COVID-19. We acknowledge that not all of these patients may even have symptoms of COVID-19. In some cases, hospitals are doing rule-out testing, for example, prior to procedure. And then on the right-hand column, we are also capturing specific data on those who are hospitalized who have a known COVID-19 positive test. So looking across these, currently, as of yesterday, the total number of hospitalized patients, either with suspected or confirmed cases, is 303. And on the right, those with COVID positive are 131. And then you can see going down the current patients in ICU beds for each of those categories, as well as current patients on ventilators. This data is critically important to us as we continue to monitor the capacity across our hospitals, and certainly for concerns historically about the risk for surge, and certainly as we look ahead on potential reopening, wanting to pay close attention to bed capacity as that proceeds. I'll just call out here our current peak, if you will, in these numbers occurred 2 weeks ago, April 7th, where we had 157 patients with confirmed COVID-19 in the hospital, and 464 with suspected or confirmed. And it has generally trended downward since that time, and we are monitoring this closely. I'm going to pass this off to Dr. Jean to walk us through our epi curve.
Thanks, Dana. Yeah, so this is our epi curve as of yesterday, and a reminder, this is available on our website in interactive form. You can scroll and drag the cursor to change the dates that you want to look at. There's also on that same interactive data dashboard a graph showing the total number of people tested by day. So good data. So as you can see, we're still seeing a clear but gradual decline in our cases by symptom onset date, starting around March 21st, March 23rd, there was a bit of a plateau, and it now looks like we are going down. Although there's that same caveat, if you look at the right side, the window there, the most recent 10 days is not very reliable because we're still getting case reports. And even a few days prior to that, sometimes we get late case reports just due to testing delays. I have heard that the major commercial labs are now kind of clearing out their queues a bit, and we're not seeing the 7 or 10 day turnaround time for results that we were unfortunately seeing a few weeks back. So this is generally good news, and not only are we seeing a gradual decline in the total cases, but also the hospitalized cases, which are the blue bars there.
Just for all of you who may be noticing that we're having some challenges with our technology, I just learned that maybe they're showing a video of us instead of actually showing the slides. So I apologize for that. I think we're going to see if we've fixed this issue as Dr. Jean continues talking about the slides. We will, of course, post the slides after so you can refer back as needed.
Okay. Next slide. The next slide is showing the daily ED visits, and this is kind of in real time up to yesterday. Well, I guess this goes to the 19th. And pretty clear pictures, very steady number of total ED visits. Really has been steady for about 3 weeks now. And then the next slide, the daily ED visits for COVID-like illness have decreased as well. The past week or two, they've been holding pretty steady around 1%, or a little over 1% of all ED visits for COVID-like illness. And just a reminder that flu season is now definitely over, so we have not seen much flu activity. So it's pretty reasonable to assume that many of these are COVID and not flu.
Great, and I've been told that it's been fixed, so hopefully you get to see the slides now. We wanted to provide an update on our latest projections, so we have 2 slides outlining our current look. As you might recall, Oregon has been working with the Institute for Disease Modeling, which is based in Washington, to develop COVID-19 disease modeling based on Oregon data to help with our response planning. This modeling is updated weekly, and you can find it on the OHA website, healthoregon.org/coronavirus. As you will see on this slide, there have been approximately 7,800 infections in Oregon estimated through these models, of which this, as of April 14th, looking back a little bit, of which 1,600 at that time had been diagnosed through testing. I think the long story here, or the short story here, based on the projections that we've shown to you before, there's clear evidence that these measures we've taken, the stay home, save lives, or social distancing measures, combined with increased hygiene and other measures, have appeared to, that we began early, have dramatically reduced the burden of COVID-19 in Oregon. The data are consistent with a stepped reduction in transmission in Oregon, beginning with a 10% decrease in transmission by March 8th, through to a sustained 60% decrease in transmission after March 23rd. You can see here that the top graph is related to cumulative infections, and the bottom, the current number of infections. And you can see these growth patterns, projected patterns, again, that are based on our current aggressive interventions. Again, overall, the interventions until March 22nd have appeared to slow epidemic growth, and the additional aggressive measures implemented on 23rd, the stay home, save lives, appeared to have reversed the growth. One more slide on our projections. This looks at specifically the number of severe cases. Those would be similar to those who are requiring ICU level of care, as well as the number of critical cases requiring hospital level of care. And similar to what I just showed in terms of cumulative and number of infections, we see again that the current aggressive interventions with stay home, save lives approaches have also been able to, are projected to be able to reverse those hospitalized cases as outlined here. You can also see that there is ongoing expectation for further deaths as outlined in the bottom graph, although quite different from what other states are experiencing. All right, I'm passing it back to Dr. Jean for a testing update.
Yeah, so as Dr. Harganani alluded to, we have just posted a guidance, an update to our testing guidance. It was posted last night, and the web link is there for to get there. If you go to that page and then go to the healthcare providers and clinical laboratories section, open up that accordion section, and you'll see the testing guidance at the top. And we've tried to make it easy to see updates, so they're highlighted in blue in that document. So just as a little background, we've been doing physical distancing and all these kind of strict measures for several weeks now, I guess almost a month, just about a month. So we think the testing availability in Oregon has increased, not only because our lab capacity has increased, but because there are fewer individuals who are presenting with COVID-19 symptoms. And so now we've got the situation where we have more than adequate capacity, and so we've decided to update our guidance to make sure we're getting more people tested. So there are several updates to this, and the first would be that we are expanding recommendations for testing of people in congregate care settings, and that includes residents, staff, children, or anybody in a care facility or group living setting, like a long-term care facility, corrections, other healthcare facilities, or all healthcare facilities, or residential care facilities. So we have had a previous limit of only 5 symptomatic people per facility for testing, and we have removed that limit to make sure that everybody who has symptoms in these settings can be tested. In addition, when laboratories have sufficient capacity, asymptomatic people in those settings could be considered for testing. Yeah, next slide, please. And the other updates, we expand the recommendations for testing to include other groups, and these are all people with symptoms only. So we are expanding to workers who provide direct care or service in multiple group facilities, or who provide in-home services. Now, a lot of these people have been tested already in the past, but we're just trying to make it more explicit since they didn't clearly fall into the other categories. So that would be hospice care workers, PTs and OTs, and other people who do in-home care or personal care. So it doesn't have to be actual medical care. Secondly, and this is a big group, essential frontline service workers who have regular contact with large numbers of people. So this would be grocery store clerks, people working in pharmacies, food service, transportation, delivery, and anything that's a critical infrastructure service where they are coming into contact with quite a few people. So again, people with symptoms in that group are now recommended to be tested. And there's no, for people in these groups, to be clear, there's no requirement that they have to have symptoms that would necessitate hospitalization or a very high level of care. If they have any fever, cough, or dyspnea, and they work in these industries or in these settings, or they live in these settings, they would count for testing. And then finally, trying to expand access for testing for underserved populations, and we've included specific groups, racial ethnic groups here: Black, African American, Latino, Latina, Hispanic, and then American Indian, Alaskan Native, as well as people living with disabilities. So our data indicate that these people have longstanding social and health inequities, and that they're at higher risk for COVID-19 and associated complications. So we want to make sure that they are tested if they have symptoms. So those are the main updates, and this is just a reminder showing the two main types of testing that we have. The main update I have this week is that the FDA has now added 3 more serology tests to its emergency use authorization, which is not the same as FDA approval. It's an expedited process, but those are the tests that we want to see people doing. I'm aware that there are many companies out there that are advertising serology tests, rapid point-of-care type tests, as well as rapid PCR or molecular tests, and probably the great majority of those do not have an FDA emergency use authorization, and there are some major concerns about reliability if they have not even had the minimal vetting that FDA is doing. So in your practices, I would urge you to make sure you're using one of the tests that's on the FDA EUA list, and they have a list on their website. Oh, and hot off the press, we have a SurveyMonkey link here. We'd love for you to take either right now if you have time, or if you want to take it later. This is a survey about testing. You know, what barriers and what labs are you using as providers for COVID-19 testing? It's a very short survey. It just asks you some basic questions about where you practice, what your specialty is, what kind of testing, what kind of labs you're using for testing, and any barriers you have. So we would love to hear from you, and we could probably report on what we find next week.
Great. We are going to put this link up on the OHA website, our Coronavirus for Healthcare Provider website. It should be located quite close to where we list information for this webinar, is where we expect. We'll also work to distribute with our health profession organization partners to try to get this broadly out there. So we look forward to hearing from you so we can better understand the barriers you're facing and address those. All right, I am now going to pass this off to Dr. Smith, who is going to answer more detailed share more detailed information about antibody testing based on the many questions we continue to receive on this topic.
Yeah, this was a hot question from our presentation last week, so we kind of did a little bit more deep dive into antibody testing. I'm sure you all are familiar with the different types of antibodies. IgM, just to remind you, is the early antibody. IgG is the later antibody that hopefully would provide immunity. For COVID-19, the data shows that people produce antibodies, but it's delayed. So probably 8 to 14 days after infection, but definitely not immediately, and not all patients produce antibodies. So it's also unclear what.
Is that after symptom onset or after exposure? Do you know?
I believe it's after symptom onset.
Yeah.
Which could be even later than exposure.
Yeah, because the numbers I've seen were 7 to 10 days after symptom onset, so that would be about right.
Yeah. So, however you measure it, after exposure, after symptom onset, there is a distinct delay, and that makes this of unclear clinical utility. So, if you do antibody testing, it shows that somebody has been exposed to COVID-19, but unclear when. So you can't really use this if we hopefully in the near future find effective treatments. It would be unclear whether it would be useful to kind of determine which patients would need those treatments. However, it's probably going to be useful for epidemiologic surveillance and also for policy decision making on reopening parts of the economy or things like that. And the WHO currently doesn't recommend the use of antibody detecting tests for patient care. So continue to use the PCR looking for actual virus for your diagnostic and clinical types of decision making. Yeah, next slide, please. So there are currently, as Dr. Jean had mentioned, there are only a few tests that actually have FDA emergency use authorization. So these are the only tests that are antibody tested that have had this minimal FDA review. As Dr. Jean mentioned, there are many, many others out there. We don't recommend using those. If you're going to use an antibody test, these are the 4 currently that do have FDA EUA approval.
And we'd love to hear on the survey. I think there might be a notes box at the end. If you are using any of these tests, we'd love to hear specifically which ones you're using, because right now I haven't heard from anybody that they're actually available in any large quantity.
Yeah, so the first test is the CELEX test. I think Dr. Jean mentioned it briefly. It's the point of care test. It's got reasonable sensitivity and specificity, about 94% sensitivity, 97% specificity. The sensitivity for all these tests are based on the gold standard being a PCR positive. The specificity, however, for these different tests varies, and it could be PCR negative, it could be just a banked blood, it could be a well person test volunteer, so that the specificity is a little bit more problematic for these tests. So going back, there's 4. The CELEX is the point of care. There's a Mount Sinai test, but it's only available in New York, so probably not of great interest for us out here in Oregon, although maybe it might be more broadly available in the future. It looks like it's got a little bit lower sensitivity, but good specificity. The ChemBio test is a blood test or it could be a finger stick. It is a rapid test, less than 15 minutes. The company had a series of different results based on symptom onset, and the best results, which are the ones shown here, are after 11 days from symptom onset. So you can see that their sensitivity, if you look at combined IgM and IgG, is about 94%. It's a little bit more specific for the IgG, which is the later onset antibody. Their specificity is a little bit lower, 90 to 94%. And they did note that the specificity varies on whether a patient is symptomatic or not, that the asymptomatic people, the specificity was higher. If you're symptomatic, the specificity is a little lower. There's also a test from Vitros, which has the one of the lowest sensitivities, only about 83%, but good specificity. There is this is a little bit longer test, but still reasonably quick, 48 minutes. And they did a large panel of cross-reactivities and found that it didn't react to any other virus, including other coronaviruses. Just as a caveat, all of these tests are just on a very small number of patients, somewhere between 50 and 200 or something, depending on the test. But yeah, the results are really small tests at this point, so we're not terribly confident that these numbers are really reliable.
Right, and that's just the case since they haven't gone through the full FDA approval process. This is very expedited. They've done some very limited testing for these test characteristics. I wanted to add that the CellX test, which was the first one approved, also claimed no cross-reactivity to other viruses, including a panel of human coronaviruses from October 2019. And then the CellX and the ChemBio are the two that have both the IgM and IgG separate, whereas the Mount Sinai is IgG only, and the Vitros was a total antibody. So that would be all the antibodies lumped together, all the immunoglobulins. And of course, the IgG is the one that would be interesting to know for potential long-term immunity. So being able to separate that from the IgM or other antibodies would be is helpful.
And just to piggyback on Dr. Jean's comment, IgG antibodies, we're not sure at this point if they will give anyone protection against future infection. That's definitely a point of current research. So if a person has IgG antibodies, we can't tell them for sure right now that they are completely protected.
Great.
All right.
Moving on, we are going to talk briefly about homemade masks or face coverings.
Completely different topic. This was another question that came up from you all last week about homemade masks and face coverings. In a healthcare setting, these are not to be used. Please, for healthcare personnel, continue to use healthcare grade, N95, surgical masks, whatever. But in the healthcare setting, if you have a visitor or a patient or other person who might be sick, they could be used for that person, but not for the healthcare personnel.
Yeah, and the exception might be if somebody had an N95 mask and covered it with cloth, but you'd have to check with your infection control, your health system about that.
Excellent point. And we did want to point out that the most effective strategies to prevent infection among the general population, including those people coming into healthcare settings, is to continue to physically distance yourself, wash your hands, use cough etiquette, etc. Following CDC recommendations, OHA has come out with guidance that cloth face coverings in the general population may reduce the spread of virus and help prevent those who have the virus from passing it on to all others. But again, please, if your patients are asking about this, yes, great, it might be helpful, but the most helpful things continue to be physical distancing, not touching your face, and staying home when sick, and all of those other really good things that have helped to flatten the curve.
Great, we're going to move on to a couple additional questions we got that Dr. Smits will walk us through.
Sure. So we had a couple other questions. One was about what to recommend about patients exercising outdoors. Yes, please. Exercise is great, both physically and mentally, but ensure that you can maintain a 6-foot distance on the trail or track or wherever the person is going. And then there was another question about our metrics that we've been putting forward about our infection rates and whether or not we include race. And yes, I want you to know that starting this week, if you look at the different data that's available on the OHA website that comes out every day, we now also break things down by cases. Unfortunately, a lot of the cases, as you can see on the slide right now, we don't have available race, but for those that we do, you can see the results there. And there is a decent number of folks who identify as minorities, Hispanic, etc., versus the general population in Oregon. They seem to be a little bit disproportionately positive compared to the Caucasian population.
And the racial and ethnic breakdown is on the weekly report.
Oh,
many of the other demographics are in the daily reports.
Great. And just to note, the data that we shared today that comes out of the weekly reports is based on what we put forward last week, and it is updated and will be shared a new version of this later today. So if you're looking for updates in the race and ethnicity data, you'll see that on the website in the weekly updates that will come out fresh again today, every Tuesday. Any other Q&A questions, Ariel, about healthcare workforce? We'll need to update the standing slide, but I think the importance here is to remind everybody we're ongoing, needing to maintain our ability to respond to ongoing COVID-19 emergencies or potentials for a future surge. And so we do encourage anyone who's interested to sign up to our registry of volunteers in Oregon. And just so you know, we have already utilized this resource in certain missions, for example, where there's been an outbreak or other particular needs with a healthcare workforce. So we appreciate those who have already volunteered and submitted their information to this website, and we welcome you to continue to do so for those who haven't yet. We did just want to spend a couple minutes talking about reopening Oregon, and specifically this is the framework that Governor Brown shared publicly on, or shared in her her public information an appearance on April 14th. You can find the full press release, her presentation, and a recording of that at the bottom link if you're curious. Hopefully many of you were able to watch that. This really provided an overarching framework for moving forward and thinking about reopening Oregon and some of the measures that have been put in place thus far to reduce the impact from COVID-19. The framework that she outlined during her press conference included a number of prerequisites that would be needed before moving forward. So that included declining growth rate of active cases, sufficient personal protective equipment, ensuring that we had adequate hospital surge capacity, ensuring robust testing, tracing, and an isolation strategy as a really next phase around containment and mitigation moving forward if needed. And then strategies, ensure that we have strategies for our hardest hit and vulnerable populations as we would move into any kind of reopening approach. The governor's office has been leading lots of work over the last week to solicit input on this framework from a variety of local leaders and industries who've been, of course, significantly affected by the physical distancing measures that have been critical and put in place over the last month, and to explore what the specific metrics for reopening might be and next steps. There's also, as you would, if you listen into this recording, note the coordination happening between other states to the north and south to understand our shared approach and how they and connect to each other. We anticipate through the significant work that the governor's office has been doing, getting input and learning, thinking further about specific metrics, that you'll likely hear more about reopening and next steps in the near future. But again, I encourage you to visit the full press release and presentation to get a better understanding of the framework and considerations that are underway for when and how we might move forward with further reopening.
Yeah, I just wanted to add that we've been in very close contact with the governor's office and all the staff there from the start of the pandemic, and providing all the information that they need to make decisions and providing guidance and information on public health strategies. So we continue to work on that and fill in more details for what we're going to do in the coming weeks. It's so that the governor can make the best decisions for all of us in Oregon.
Great. Closing, we just want to let you know we've been monitoring, of course, attendance on these and still see several hundred at least people participating on Tuesdays and even more so on Thursdays. We want this to continue to be beneficial to you. We will maintain them as long as there's interest and need for this type of information. We really invite you to let us know what other topics you want us to address, as well as any questions that remain. So you can go ahead and insert those again through the chat box, or you can send us your questions or topics you'd like covered to this email listed here at the bottom. Again, as a reminder, please do not expect individual responses to the emails coming in, and please do not send personal health information to that email address. We really do want to continue to meet your needs for getting information out across the state for healthcare providers. We will continue to bring forward hot off the press updates to our guidances, new policies put in place. We'll share with you further information about reopening Oregon and data to help you understand what the impact of COVID-19 has been in our state. This Thursday, as usual, we will also continue to host our Project Echo sessions that include staff here from OHA, as well as the OHSU Project Echo team and additional invited content experts. We encourage you to consider joining if you haven't. It's a beautiful platform that allows for lots of cross discussion between participants on the Echo session. I think often you learn more from each other than you do for the presenters, but we found that is a really useful platform and has been really useful to people attending. So we encourage you once again to join us on Thursday for that.
And one more reminder to take the survey. The SurveyMonkey link that was shared, I think will be on our website, and I don't know if we can share it out at the end of this again, but we'd love to hear from you. And I wanted to emphasize, in case I didn't emphasize this earlier, that our guidance for testing is just that, it's guidance. We recognize that healthcare providers can make clinical decisions about their patients, and of course that's not done in a vacuum. You have to take into account finite resources, including not only the tests themselves, but testing collection kits and PPE. But we are absolutely not trying to get in the way of a provider who thinks that a COVID-19 test is needed for a patient. So we are not the gatekeeper. This is just guidance for you, and we hope it's helpful.
Okay, once again, we just want to say thank you for all of you, particularly those working on the front line. Your work is incredibly important to our state, and we appreciate all that you do. Please, again, let us know any further information we can help you with, and we look forward to joining you again Thursday and ongoing next week. Thank you.